So hello everyone, welcome to our forensic nursing webinar. I'm Patrick Chu. I'm the policy initiatives lead here at ARNBC, and I'd like to introduce our presenter, Sheila Early. Sheila graduated from the University of Saskatchewan School of Nursing and has 4 decades of experience in healthcare. She is currently faculty within the Forensic Science and Technology program at Speciality, acting as a coordinator and instructor in the Forensic Health Sciences option. Sheila also practices as a legal nurse consultant and educator. She has been known as a top leader in the field of forensic nursing, where she developed the first sexual assault nurse examiner program in BC in 1992, performed the first medical forensic examination by a nurse examiner in 1994, and developed the first Canadian classroom curriculum for forensic healthcare in 2005. Sheila has also provided the initial education for sexual assault nurse examiners across many Canadian sites and has provided continuing education both nationally and internationally. So the presentation is going to be about 45 minutes. We're going to leave 15 minutes at the end for any questions. And everyone is muted on the line right now, so if you would like to ask a question, you'll see on your right-hand side of your screen, there's a little taskbar. Expand the red arrow and just type your question in, and we'll read it out loud and address it at the end of the presentation. So I will hand it over to Sheila.
Hello, everyone. With the time zones, I'm not sure which time zone everyone is in, but it's afternoon here in British Columbia, so I'll say good afternoon. First of all, thank you for arranging this webinar, Patrick, with the ARNBC. I'm very pleased to be part of a webinar for forensic nursing. My husband actually says that I often will do things above and beyond just to promote forensic nursing here in Canada and globally. So today I would like to go over a couple of things with us. The first one is that, I'll just get this moved. Oh, Patrick, I think it moved. It's not giving me control again. Did I get your control back again?
Yep.
I seem to have lost it.
You can try once more.
Okay. No, not happening.
How about now?
There we go. Thank you. So the objectives for today, for our time together, are first of all to give you a very brief overview of forensic nursing both in Canada and globally, because they're all at different timelines. And I think those of you in Canada will be pleased to know that the actual origins of forensic nursing as we know it in North America actually happened in Canada. And more about that in a moment. Also to describe the roles that forensic nurses now have in Canada, and eventually in part 2 we'll talk about their roles for the future as well. And when we look at forensic nursing, the first thing that we need to look at is the fact that all specialties need scope and standards of practice, and I will address that as well. So when we look at what forensic nursing actually is, there's a number of definitions. I usually go with the shortest one because it makes most sense to me anyway. In September 2008, the International Association of Forensic Nurses spent a great period of time looking at a workable definition for forensic nursing. So the mandate is forensic nursing is the practice of nursing, first and foremost nursing, globally where healthcare and legal systems intersect. Often I say they actually collide, because that's usually what happens, especially in the emergency department for those of you that work in emergency departments. When we look at the word forensic, there's a misunderstanding that it means police, where actually it doesn't. It actually means regarding the law, pertaining the law. And how it came about is in the Roman times, people would get up in the marketplace on a pedestal and they would tell their fellow countrymen about what they thought was right and what was wrong about what was happening. So it's basically said in the forum, tell me what you think, or such and such a shopkeeper is charging too much money, so and so stole from me, etc. From that, we evolved what is known as common law. Today, it usually means legal or related to the courts is the acceptable meaning of forensics. Certainly, law enforcement is part of it, but it is actually focusing on the law. Another definition that comes about is the specialty of nursing, which combines the forensic aspects of healthcare, along with scientific investigation and how survivors, victims, and perpetrators of all sorts of violence, trauma, and criminal activity and accidents are governed by. And that's usually where we get this collision between nursing, medicine, law enforcement, and as well as the legal and judicial systems. First of all, often forensic components to healthcare are not recognized, and that's probably the biggest thing that eventually will have to change within healthcare. Also, too, those of you who work in emergency department know very well when you have a police officer in the department, they want information that you cannot give them. So that's where the collision comes in. Globally, well, forensic nursing may well have started with Florence Nightingale. The Lady at the Lamp worked in violence and trauma during the Crimean War. And actually those are the beginnings of nursing working with victims who have specialized needs beyond health care. It's been a role in the United Kingdom for several years, actually around World War II. And it's mostly focused on forensic nursing in psychiatry and mental health. And it's been a very active role. In fact, if you look today, the leading components of forensic psychiatry and mental health are still from the UK. Nurses in the USA actually started doing examinations on the first sexual assault patients around 1976. And there were actually 3 communities. One was in Memphis, Tennessee, Minneapolis, Minnesota, and then Amarillo, Texas. They were actually working in isolation. But they actually came after an event that happened here in Canada. So other forensic nurses also worked in forensic psychiatry units and forensic correctional units throughout North America as well as the UK. So when we look at Canada, 1975, Dr. John Budd, who is actually a forensic pathologist, and he resides here in Vancouver for those of you who are local, he actually was the interim medical examiner in the city of Calgary, Alberta. And what he was trying to do is find people to help him do the investigations of death. And he tried a number of professionals, including social workers and paramedics. But when he started hiring registered nurses to investigate the deaths that he was dealing with, he found they were a perfect fit. They had the medical knowledge and forensic, and as well as the nursing knowledge behind what would cause a death. Also, when he was investigating deaths within the hospital system, the nurses knew the charts. They knew where documents were. They knew how to find things. And they also had the ability to communicate with the survivors, the families, the friends of those who had been deceased. And he found after a 5-year study that registered nurses were the key to assisting him in death investigations. So again, in 1976 came nurse examiners, but in death investigation was here in Canada. Fast forward to 1986, when Virginia Lynch, who was actually a forensic nurse, she was actually a psychiatric nurse, did not have any forensic education, but she was invited to attend a death review and attend an autopsy. And from that, she realized that there was a great discord between healthcare and the forensic investigation of a death. And she was then in the University of Texas, and she started to develop her forensic nursing model. And if you're interested in that, certainly send me an email and I will make sure you get it. It's in several of her textbooks. What she did was she united forensic nursing science, forensic science, and the criminal justice system into a model, because they interact so closely that they cannot really be separated. In 1992, there was a gathering of like-minded people. And when I say that, they all didn't have the internet. Remember that. In 1992, that wasn't a luxury that was available. It was mostly phone calls, letters, and one passing the word on to others. But a number, 74 actual folks met in Minneapolis, Minnesota, and there were 2 Canadian nurses there. One of them was Bess Harris, who eventually was the co-founder of the forensic nursing program in Winnipeg. And they were there attending the conference, and after much debate, the word international was voted on. Also, the term forensic nursing rather than sexual assault nursing, because of course Virginia Lynch attended it along with Dr. Linda Ledre and any number of people. They're often known as the original 74. Wanted this to go beyond sexual violence, and that became the key to making forensic nursing a specialty. So thus we had the birth of the International Association of Forensic Nurses. In 2000, the first Canadian Forensic Nursing Conference was held in Alberta, and there were a number of key people involved in that, including Arlene Kent Wilkinson, Kathy Carter Snell, and Kathleen Soji. They were all involved, as well as a number of other Canadians. It was the first time that IFN had a conference outside of the United States of America. By that time, it was 5 years old, and that was actually, no, it was actually 8 years old, sorry. And it was kind of the beginnings of recognition within British Columbia. 2006 was the second conference, and then in 2007 there was a big milestone where the Canadian Forensic Nurses Association, they actually recognized forensic nursing as a special interest group, and that was under the name of Forensic Nurses Society of Canada. And that was kind of the first time that it was recognized that this was something that needed to be on the radar for the Canadian Nurses Association. Unfortunately, we're still not recognized as a specialty, and there's work being done on that. In 2009, another milestone for Canadian forensic nursing, when Kathy Petronelli Taylor out of Saskatoon, Saskatchewan, was actually chosen as the first Canadian editor of the Journal of Forensic Nursing. And that's the IFN publication that is this main source of information around forensic nursing in a timely fashion. Actually, Cindy is still editor of that journal, and a number of Canadians, including Colin Harris, who is a forensic nurse, and others have actually published. Other ones are, of course, Sheila McDonald out of Ontario. Okay, 2011, and I know this history sounds okay, well, why do we need to know the history? Because if we don't know the history, we don't really know where to go for the future. In 2011, the society changed its name as later, but it became the first affiliate, and there's a key component there to the word affiliate. It's separate but symbiotic, which means each helps the other. It was the first affiliate for the International Association of Forensic Nurses, and it is still the only affiliate. There are others in the rings, but we were still the first. 2011 also brought the third Canadian conference. 2014, I had the pleasure of being elected by the IFN members as the president for IFN, and that was a milestone. And what it did is it said that the International Association of Forensic Nurses actually became global. Many times, it was a unique USA specialty, and that's fine, but we also got a broader exposure here in Canada and globally as well. So it's an equal opportunity organization where anyone within the framework of forensic nursing can become part of that association to the highest level. I also know that there are the nominations for in the International Association of Forensic Nurses has just gone out, so please have a look and start thinking about awards, and eventually the nominations for the Board of Directors will also come out as well. So keep an eye out for you. If you have any difficulty finding that information, please just email me and I'll get back to you. Also, we want to make sure that, go back to one more thing. In 2006, and I'm actually going to show it up because hopefully you'll be able to see it. It's, yeah, there we go. It's the Core Curriculum for Forensic Nursing, which is published by the IFN. This is kind of the Bible, if you want, for courses and expansion of the educational part of forensic nursing, which is very much needed not only in Canada, but also globally. And this year is a very milestone year because we have the second Canadian as president of the IFN, Elizabeth Loudon, and also the conference has come to Canada again, and that will be in Toronto on October the 11th to 14th. So if those of you who are interested, please make plans to attend. It is again a milestone and a touch place, if you want, for all forensic nurses in Canada to come together. As yet, the Canadian Forensic Nurses Association has not been able to hold a conference, so this will be being part of it is very important. Okay. So, what makes a forensic nurse? That is a couple of things that are a little different. Sorry about that.
Leave a message. We'll return your call. Thank you.
One disadvantage of working at home. Okay, professional nurse education. That's key. Okay, so this is a role that is filled by registered nurses. Also, of course, nurse practitioners, etc. But you need that nursing education that is complete from birth to death across the lifespan. Then add a layer of forensic nursing education combined with forensic science education. This isn't something that is part of nursing normally. So the forensic science component has to be taught along with all the other components of forensic nursing. So that's why we have to rely on other experts to bring in their expertise for healthcare providers when we're looking at forensic healthcare needs of individuals. If you'd asked me back in '92, when Patrick said, I initially started the nurse examiner program at Surrey, that I would become an expert in DNA analysis, meaning what are the different things involved around DNA, blood spatter analysis, drugs in the toxicology components, I would have said, but I'm just a nurse. And that is a fallacy that we all have to get over, is that you need that professional nurse education, you need forensic science, and you need forensic nursing education, forensic nursing science, as Virginia Lynch would say. All that you put together, and you get a professional nurse trained to provide care and treatment to victims of both the living and the dead. And that's another key, too, of violent crime or traumatic events. This is not looking just at victims, but is also looking at perpetrators, both living and deceased. So it encompasses violence and trauma across the lifespan. Sometimes it includes crime, okay? Not every violent episode includes a crime. Not every traumatic incident involves a crime. However, all have a forensic component to them. And if you're looking for more information around forensic nursing, Donna Bader's book is very good as Forensic Nursing, a concise manual. Key components to the forensic nurse. How does this differ from nursing as a norm now? Well, if you look at the slide that's in front of you, what does this remind you of? It reminds me, and is key to, the nursing process. So, identification of trauma. That's our first goal as a nurse, isn't it? To assess. Investigation. That's part of looking at collecting both objective and subjective data. Recording or documentation of the history regarding whatever our patient is presenting with. That's the same for the forensic nurse. And then there's the intervention part, which can include collection of evidence, specimens, or samples with the patient's permission. The key here that it's different from nursing is that when we intervene as a nurse, we usually have acceptance by the patient to do a medical procedure. And sometimes we forget and say, we're giving you this drug. And they go, oh, no, you're not. On the other hand, for forensic care, we always need to have the patient's consent or client's consent, whichever the case may be, because it's not deemed the component to healthcare as yet. Once we do determine if there's anything that can be collected or saved, this could be as simple as a piece of clothing, Then we are documenting all of that, including the history and the intervention part. And then we do an evaluation, and that is often called the post-investigative review. For those of you already in forensic nursing, you know that's usually a legal report. Or it can be a simple documentation evaluation as to what the care was provided and what the patient's choices were for that forensic component. So when Lynch delineated these in 2005, she used the nursing process and tied it to the forensic nursing process. When we look at the next component, having trouble forwarding again, Patrick. Seems to lose it. Okay. We move on from what forensic nursing is to what is called clinical forensic nursing. This is the backbone for the nurses who work within forensic field here in Canada and the USA and globally. So what it means is that nursing has evolved into a role, specialty status in only a few countries, but eventually will be globally. And I actually have no doubt about that. It's multidisciplinary in nature, so we're caring victims and perpetrators of all those three things. In fact, we get to the point where we think, okay, is all our work related to these three items? And even, yes, they are. However, they're intertwined. And as I said, crime may not be part of a trauma, but it may be. Violence may or may not be. And often that is determined by our patients' and clients' consent or non-consent. They will always need some form of medical care. Whether the forensic aspect comes on board, that's another story. What Lynch stated too in one of her books, and the references, by the way, are all at the end of the presentation, address the previously unmet needs. And I think that's the key. Unmet needs during the time they are caring for the patient. Often, as she says, one-on-one. Because that's the interaction that actually develops that trust and that understanding and the ability to explain the options to our patients and clients so that they can make informed choices. I think consent in the medical field is often assumed. In forensic field, no, it is not ever assumed. It must be earned by communication and by explanation and by providing both the alternatives of doing whatever to not doing it. So she also, and you can guess that Virginia Lynch is actually what I consider the Florence Nightingale of forensic nursing. She encompasses living victims, living patients, the victims, the accused, and the condemned. So that's where forensic psychiatry and forensic mental health come in, and death investigation. So it is not just the patient in front of us. Okay. When we look at forensic nurse and how it differs from other healthcare providers and healthcare is the forensic nurse must be unbiased and neutral. The advocacy here is for truth and justice. As a nurse, we're always advocating for our patients' well-being, for their needs, their healthcare needs, and anything that comes that we identify in our assessment process that nurses can assist patients with. However, the forensic nurse does that other layer of unbiased evaluation, unbiased evaluation of both objective and subjective data, and becomes an advocate for the truth and justice in that they present the neutral picture rather than a biased one. And you know, our biases are so strong that sometimes we don't even realize that we have them. And it can be as simple as saying, and you know, I'm going to paraphrase some of the words I often hear as well. Why does she just leave him after an episode of intimate partner violence in the presentation to for healthcare? Well, because there may be a number of reasons. So what Virginia Lynch has really given us the mandate to be unbiased, value neutral, and advocate for truth and justice. And that comes really important when forensic nurses actually go to testify in the courts of law. Okay, living forensics. So forensics is actually a little more than death investigation. there's a number of things listed on your screen, and I'm going to highlight only a couple of them because it's quite extensive. Interpersonal violence. I don't think I need any more explanations on that. I think that anybody who's been a nurse for more than 2 minutes knows about interpersonal violence. Forensic mental health, correctional nursing, legal nurse consultings, and I encourage anybody who's interested in legal nurse consulting to actually access the Journal of Legal Nurse Consulting online out of the American website. It has, in the December issue, is a whole issue on forensics and legal nurse consulting. Emergency trauma services. Actually, that's becoming the norm for many forensic programs to be housed under, because emergency department is kind of where the access around trauma and violence often happens. Not always, but often. Public health and safety, and I'll speak a little bit more about that in part 2 on March 15th, where public health and safety have recognized that violence is a healthcare issue. Death investigation, of course, has been going on since the 70s. And another one that's not often thought about is the mass disasters. And all we need to look at are the events around Hurricane Katrina out of New Orleans and the massive amount of violence that happened after that. We look today at mass disasters, such as 2 days ago when 74 bodies were found after a ship carrying refugees across the Mediterranean sank. It actually wasn't even a ship, it was a floating rubber raft. So looking at all those components, you see where healthcare, specifically nursing, medicine, is involved. We also go on to the next page where there are the more common ones that you may know about, and the forensic nurse examiner. And those of you are saying, well, what's this forensic nurse examiner name? I know about sexual assault nurse examiners, but what about the forensic nurse examiner? It's because programs are actually expanding to do more than sexual violence. When we look at sexual violence, it's across the lifespan. It's from the child who is 2 years old to the elder who is being abused in a nursing home. And actually, just today, of those of you that are local in the Vancouver Sun, is a huge article on patient complaints within the healthcare system, and one of them was an elder who was sexually assaulted within the healthcare facility that they were a patient in. Emergency and critical care nursing. That's probably the background, or could be the background for many forensic nurses to have an opportunity to have their expertise useful. Perioperative nursing. We know when there's trauma and violence, often that means that there's an intervention needed within the operating room facilities. Excuse me. And then we get to the clinical forensic nurse specialist, which isn't a role that is really well known here in Canada. However, it's getting there, because we have experts who are now not only providing their skills in sexual violence, but in elder abuse, in child abuse, in human trafficking, and other areas that we have yet to identify. When we look at all these roles, we know that there's, it's nowhere to go but up. When we look at the roles, the problem is, when we get to barriers, is funding. Here, there's the forensic correctional nurse, the mental health nurse, forensic youth nurses, also the forensic nurse consultant, and I probably get at least 1, 2, or 3 emails a month about from a nurse wanting to know how to become a forensic nurse consultant. And the first thing I say to them is you have to be an expert in your specialty, whatever that is, and then apply that knowledge and experience that you have to the forensic components, which include law enforcement and the justice system, and the forensic nurse investigator, of course. That's also, for example, when we talk a little bit about roles in here within Canada, you'll see one of them. Legal nurse consulting, very much like the forensic nurse as well. Nurse coroners and medical examiner roles. We have many nurse coroners here in British Columbia and in other areas of the country. And also the medical examiner system in Ontario has hired its first nurse manager, that was last fall. There's also been a forensic nurse working as claims reviewer in WorkSafe BC, investigating fatal and serious incidents, and forensic nurse educator, and which is really needed is the forensic researcher, forensic nurse researcher. And those are coming. There's several within Canada, and we also need many more. So if you have a project for your master's or your PhD, start thinking about a forensic component to it. Okay. When we look at standards, there's nothing here in Canada. And I say that not facetiously, because first of all, we need to be a specialty and then develop our Canadian standards. Reality is we default to the International Scope and Standards of IFN, which I'm holding up now for you, those who have not seen it. And it was actually developed in 2009. It is currently under review, so you can't get it off the but it's going to be released, I'm sure, within the next few months, which is timely. 2009, 2017, that's a lapse. There are a number of standards, and I'm not going to go over them with you because they're pretty straightforward. They follow the guidelines of all other organizations in nursing that have scope and standards of practice. And they are focused on the different roles within forensic nursing. So it basically looks at the roles and both clinical, educational, and research roles and what needs to be addressed within the scope and standards of practice. When you look at this, who defaults to this? Well, you know, as a legal nurse consultant, I will default to this because there isn't anything I can use in Canada. I will, of course, also default to the Canadian Nurses Association and the particular standards that are in the province that the consulting work is in. And you know, they've never failed me yet. And my first role was in case was probably 1993 or 1994. I've kind of forgotten. You know, that old-timers disease again. And they've never let me down in the ability to identify, unfortunately, the word fault comes into mind. And you know what? In most of my cases, probably about 90%, it is not nursing. But my job is only to evaluate the nursing scope and standards of practice and whether that clinical practice was met by that individual nurse. So, why do I, as a nurse, need to know about forensic evidence? Which is the key thing. The most common thing that nursing does is destroy clothing. Whether you're working in the emergency department, whether you're working in the intensive care unit, somebody comes in, they're still clothes. The operating room, clothing could be the most important evidence that your patient/client needs if they so choose to go forward in anything regarding the criminal justice system or the civil. It's the one thing that can be scientifically matched to a known individual or item, and it is not necessarily DNA. It can be, but it can be other things. And we'll get some examples when we go into the 3 cases that hopefully you'll send to me. If properly obtained and examined, it becomes a very powerful tool. And when we look at violence, trauma, and crime, it's kind of like building a story about what really happened. We often have 2 individuals who may be part of trauma, violence, or crime, and they do not agree as to what happened. So it's up to those individuals, law enforcement, healthcare, others, to obtain to the best of their ability the things that will maybe help the court of law when needed. Many times it is not needed because, as we know, crimes and violence go seriously underreported in all countries of the globe. Statistically, we know that 9 out of 10 victims of sexual violence will not report to law enforcement. Actually, I just had a study cross my my horizon from Tamara Dudley, who's a master's student out of UBC, and her data from the Sea to Sky Highway still substantiates that. Most do not report sexual violence. Nurses care for these patients, and that's why we have to look at being the advocate for that patient if they so choose to go ahead with some sort of forensic involvement. So we also look after the perpetrators. When I was an emergency nurse many years ago in Saskatoon, Saskatchewan, I had a 3-car crash with probably, I think it was 11 individuals. And so identifying who were the drivers of those 3 vehicles was a mismatch. One person died, 3 were critically injured, and then there was a rest odds and sods that had come in. But the car crash has never left me, because at one point I was actually caring for the driver of the vehicle who made the crash happen, if you want. And when I looked at all that, now I look back and thought, oh, there was so much more I could have done. And you know, if he hadn't identified himself as a driver, I don't know whether we would have ever known. Because our job was to save lives, and we didn't care too much about what evidence we were saving or destroying. And we destroyed a lot, including myself. Okay. When we look at examples, I'm going to go back to number 1. I'm looking to see if there's any questions out there, because I've kind of stopped nonstop for the last 30 minutes, and I really would like this to be a little more active, interactive participation for those of you that are attending. When I look at this, I didn't put examples here because I wanted the audience to send me an example that I can work into this presentation and identify you the forensic components to it. Because, you know, when we look at our practice, that's what we need to do, is to look at each individual situation that we meet on a daily basis, and how could I have done this differently, knowing what I know about forensic nursing now. Even the simple thing about don't destroying clothing can become an extremely powerful tool. So for those of you out there, can anybody have brave enough to send an example that I can work with from your own practice? I'll just give you a minute or so to type it in so that I can see it. It could be a car crash, it could be an intimate partner, it could be somebody that had something that you didn't really know what to do with, anything along those lines. Okay, I'll give you another minute or so, and if not, I'll go ahead with a couple of ones and examples. Okay. Okay, I'm going to go ahead in the essence of some time. One of the examples that I like to use is obviously a car crash, because that's one thing that we do see in healthcare regularly. I know that the care that we provide to individuals after a motor vehicle incident is very different than what it was, you know, many years ago when I was first working in emergency. 2 things. One is the first thing that we've learned to do is that we look for seatbelts injuries, because they can be an indicator where our patient has suffered in both external and internal injuries. So this is actually, all my case examples are all true, because only minor things are changed to identify if there's an identifier in there. This was a car crash where a male, 40s, in his 40s, had crashed into a brick wall. And when he was found, the front end of the car was obviously very badly damaged. He did not have a seat belt on. He had an injury to his head. There was actually an imprint on the windshield where his head had actually hit. It wasn't, it was disintegrated, but not a hole kind of thing. And he was unconscious. Someone had heard the crash, and it happened very early on a morning, and had heard the car crash and called both ambulance and police. When the paramedics came to remove him from the vehicle, they basically, strapped him, collar on him, got him out and into the hospital. And of course, the police looked at the vehicle to see if there was anything there, and with indication of any alcohol or drugs, etc. And the man did not have an ID on him. But of course, with the vehicle, the police were able to find a registration, and eventually he was identified. When he got to the emergency department, he obviously presented with a head injury because he was unconscious. There were many number of interventions that were done. His clothing were cut off. All his clothes were cut off. What was done with them was that they were actually thrown into the garbage, and because they were deemed unusable, so okay, let's just throw them into the garbage. And luckily, in the trauma room, the garbage doesn't always get taken out immediately, and that's a key point there. And so he was treated medically for head injury. He had a drug toxicology screen done, which would show blood alcohol and also any drugs that he might be involved in. But remember that these aren't going to show up instantly. And they were still continuing care for him. He was intubated and had, the usual tube in every orifice done. And by that time, his family had started arriving. His wife had arrived, and she was able to give the information that they were estranged and going through a divorce process, and that her husband had been despondent for a considerable amount of time regarding this, particularly because it was putting a financial strain on both him and his wife. So, the thoughts around this were, okay, is this intentional or is this unintentional? And you will notice that I don't use the word accidental. It was a motor vehicle incident. It wasn't a motor vehicle accident. That's because my language has changed considerably over the years when we're looking at the forensic components to healthcare. He had a laceration on his forehead, which was quite deep, actually, because of course, the glass from the windshield. And eventually, he was transferred up to the intensive care unit after CT scans and showed that there was a head injury. So he was eventually put on a ventilator, even though before he had been breathing on his own. And he was cared for in the emergency department, in the ICU department. On investigation, the police, of course, were looking at, was he forced off the road? Was there any other things? And this is before webcams were everywhere that you could see. On complete investigation, it was discovered that the police had actually found a note jammed in the seat of the car when they examined the car more fully, and it was actually a suicide note. So he eventually died. So the long and short story of this is, here was an individual who had crashed a car with the intention of committing suicide, which might never have been discovered if he hadn't left the note. And of course, this meant a number of things for his family. One is that the life insurance policy could well have been voided, that there wasn't the grieving process that normally happens after an unintentional car crash, but that this was an intentional one, and he had deliberately ran his car into the wall. So implications for family, for friends, for the forensic components, legally, around the healthcare as well as life insurance. So we all know as well that long-distance truckers tell us that there are often individuals who perform what is called suicide by road accident, or incident, that they actually crash deliberately into big semi-trailer trucks. Why? Number of reasons. One, it's a form of suicide that may not be recognized. Now, the individual I talked about actually left a note. That's not always the case. In fact, it's more likely not to be the case if someone has this intention. There's also suicide by police officer that we need to look at. All these things have many legal ramifications. So that's one example of whenever there is a motor vehicle incident, there may be legal implications that you don't know. What would we have done differently in that case? First of all, it would have been to save the clothing, because there could have been remnants of drugs, alcohol, even that might not have shown up, but would have shown previous use. He was actually on antidepressants, but of course they were not in the vehicle, so that was not known in the beginning. Talking to the family immediately and getting the details that provide that objective data to put together with the subjective one that you see as well. So a number of things. Any questions out there that coming up from the next one, because I do have another one that I'd like to share with you. Okay, example number 2. This one is, again, absolutely one that I can share with you that is from my own experience. This was a gentleman who came into the emergency department that I was working in at the time, and he had he was a gunshot wound. And the gunshot wound was actually to his upper leg. And in my lack of experience, I was concerned about saving his life first, and at that time it was actually a feather in your cap, if you want, to be able to get somebody's clothes off as quick as possible. And being the fastest scissors in the West was kind of a cool thing to be. Well, I very nicely cut through that bullet hole. I mean, it was nice and round, and it was right in front, and I was going up the seam of the, I wasn't going up the seam, which is giving a little hint about what to change. I went right up the front of his pants, and I remember, actually was conscious, and I remember saying to him, I am so sorry, I'm cutting these pants off, they look like new ones. And after all the healthcare things were done, the police came to investigate, because, of course, this is a gunshot wound. And they said, where's his pants? Oh, I was so proud because I'd saved them. I hadn't thrown them in the garbage, like some of my coworkers had done in the past. And but I had cut through it. And I so believed that this was someone had inflicted this wound on my patient that I was not thinking objectively. So, long story short on that, it was that when a forensic scientist pieced together those pieces of clothing that I had cut off, and they looked at the angle of the entry, because after, of course, the guy went to the OR because he had to find the bullet, the angle of entry, and luckily the surgeon had probed it, said that this was a self-inflicted gunshot wound. So when he said that, oh, so-and-so shot me, it turned out to be not true. He had actually shot himself for reasons that are still to this day beyond my comprehension. Anyway, I didn't make it easy for the forensic scientist. So what I would do differently is I would assess much more objectively. Okay, this looks like a gunshot wound, intentional. It could be self-inflicted, so therefore I'm going to preserve that bullet hole. And I would have cut up the seam of those pants rather than right through it. Same goes for a stab wound. A same sort of thing is you don't cut the stab wound if it's in the shirt. And also a good point is to have your emergency physician not to put the chest tube in through that stab wound, even if it's in the right intercostal spot. Use another one, because the forensic pathologist, if that unfortunately is the case, but certainly a surgeon, if he or she documents well, can tell the angle of that stab wound. When we look at those two incidents, they seem minor, but they could have affected so many number of people. The police were no longer looking for somebody who was out there with a gun to shoot people. They were focusing on the patient who had an intentional injury. And that becomes a key, too, for injuries. Are they intentional or are they unintentional? And I actually have my third case, which is a child abuse case. I will elaborate on that a little more. But I see we have 9 attendees. If there's anyone out there that has any questions, please send them along. because, I get tired of hearing myself talk. Anyway, we'll move on to example number 3, and I don't see any questions. So,
there's actually 3 questions. Do you want me to read them out?
Oh, sure. Actually, let's do that before we do example 3.
Sure. So the first one is, what are the confidentiality guidelines when answering questions from law enforcement about your client?
Okay, good question. Depends on what province you're in. What province is the question coming from?
BC.
Okay, well, that's fairly easy because you've got the Freedom of Information and Privacy Act, which tells us that we cannot disclose healthcare information without the patient's consent. This is really where that collision happens. So I'm going to assume that this is an emergency nurse asking this. The key thing is you can't. You can, when you're talking about healthcare, you have to have the patient's permission. And even more so if that person is an infant, because that's also governed by the Infants Act. So what you need to consider is, what is the question? If somebody comes forward, a police officer comes forward and says to you, I'm looking for Sheila Early. I understand she's here at the emergency department. What you as a nurse need to do is come to Sheila Early and say, there's a police officer out front at wherever, and he or she is asking whether you're here or not. Do I have your permission to tell them that you are here? So the patient gets that choice. Okay? If it's a crime that's being investigated, the police may already have information that says that this person is a suspect in something. So they have to deal with those legal issues around being able to talk to that person. If it's about, hey, I hear Sheila Early's here, so what's wrong with her? She can live or die. Again, that's a healthcare issue. So, as much as we'd like to, the response that is probably most appropriate is, I can't tell you that due to the Freedom of Information and Privacy Act. And believe me, I've had these battles with police, particularly over a 13-year-old who they went and told her parents that she was at blank hospital after a sexual assault. The problem was they said she was being cared for after a sexual assault. If they had just said, we found your daughter drunk in the street naked, that would be different. But as soon as they said that she was being investigated for a sexual assault, that breached her rights as an infant under the Infants Act in BC. So how do you work around this? Sometimes it's hard. Another issue around what you tell police is you have to make sure that all those people out there in the waiting room or in the parking lot are not talking to police about your patient's care and a medical condition without that patient's permission. For example, you have a woman that comes in that is suffered from severe intimate partner violence. She's beat up. Right now, BC does not have a law that says you have to report intimate partner violence to the police. We do for stab wounds and for gunshot wounds. Ontario has that act, but it is not always enforced. So again, you have to look at knowing the laws very closely about what you can say and what you can't say. And you know what? If in doubt, you say, you know what? I'm going to refer you to our manager because I'm not just sure what I can tell you or not tell you. And then sometimes it means that the manager has to call legal advice with risk management, which as a nurse educator I did regularly. And that's what they're all being paid for, the lawyers. So the answer to your question is know your laws, start getting more information about the ones I've mentioned if you don't already have it, the Freedom of Information and Privacy Act here. There's an officer in each facility, like healthcare region, by the way. And also to the Infants Act, and also the mandates of when you get presented with a warrant. That's the other thing. I know that some health authorities have a process that you have to go through when law enforcement makes a request for information. And we're not talking records. We're talking, clinical work right now on the spot. And I hope that answers your question. If not, just let me know. What's the next question, Patrick?
We have one question asking about what the name of the authors are of the textbooks you showed earlier on in the presentation.
Okay, the both of the documents now the forensic nursing. I'm holding it up again. Oh, get it onto the webcam here. Forensic nursing scope and standards. That's unfortunately it's not available on the IFN website because it's being revised. But that is the one that is should be available within the next couple of months. I'll check with the president and see what the status is, and then I can maybe I'll certainly have it available for the March 15th presentation. So that's this one. The second one is the core curriculum. I never said I was a techie. Is the core curriculum forensic nursing, and it is edited by two individuals, and that is Bonnie Price and Kathleen McGuire. It is also available on the International Association of Forensic Nurses website. I believe it goes for somewhere around $99. It is the core curriculum stating all the different categories of forensic nursing and what needs to be taught in courses that reflect forensic nursing education. It's kind of the educator and researcher's Bible. It's also, by the way, Bonnie Price is a clinical practitioner. She's the forensic nurse coordinator in Richmond, Virginia of the forensic nursing program, and Kathleen McGuire is she's actually in charge of education, etc. at IFN, and you can actually contact her via the IFN website at Kathleen McGuire, M-A-C, sorry, I lied, M-A-G-U-I-R-E, okay? And they're both put out by Wolters Clower Publishing Company, okay? In this document is the heart and soul of many forensic nurses. Okay, next question.
I'm just looking up the clock. We have 3 more minutes.
Okay.
You just want to address this one quickly. If a nurse wishes to pursue a career in forensic nursing in BC, where is the best place to begin?
Okay, a caveat, I work for BCIT and Forensic Health Sciences, so just so you know that. I hate to say this because it's a negative, but we happen to be the only viable credential in Canada. So I will give you the complete list where you can get in more education in forensic nursing. But BCIT currently offers a 2-year part-time study certificate in forensic health sciences, and that's my option, so you can email me. And it involves 11 courses, which would total a number of 30 credits at the end of the day. It includes forensic nurse examiner, forensic introduction to forensic health sciences, forensic health sciences and violence and trauma. We also have a pediatric nurse examiner course. We also have a wounds and blunt trauma course, which we're moving online. And I do want to caution you that you can take those as continuing education, which is what I would recommend right now, because we're moving the whole process to a graduate certificate. Why? Because we have found that the people coming into the certificate already have a degree. If you're a nurse, you have the necessary degree to take the courses. And we also have, criminology students, as well as we even have a biochemical engineer listed in our certificate. So we're moving to a much shorter, less money, fewer courses certificate, and that's being worked on right now by one of my colleagues at BCIT Forensic Health Sciences, Colin Harris. Outside of British Columbia, we actually are doing streaming of courses as well. Our introduction course is also going to be streamed, actually starting the end of March, and we have online courses too. Not as many as we would like, but we're getting there. There are still Mount Royal University. They have courses on demand. Their certificate has been on hold for a number of years, but you can also look at their website, Mount Royal University, and look and see what courses they potentially can offer. I know they offer a forensic nurse examiner one. At St. Francis Xavier University in Antigonish, Nova Scotia is a 6-credit forensic nursing educational course. That includes the education to become a forensic or sexual assault nurse examiner. And that is taught by Susan Wilson out of Halifax. There are also a couple of other places where you can look to find courses. They're not always available. One is at George Brown University out of Ontario, and Seneca College out of Ontario often will offer some of our comparable courses. Reality is those are the only places in Canada where you can get educational institution courses and credits. Many students do look at the United States. It's extremely expensive. However, they are available. I know 2 of my colleagues have taken courses out of Duquesne University and also Aspen University, which is an online university. So they're available. University of Riverside is also one in the United States that I'm aware of. Canadian ones, email me, because I can reiterate all this for you and not have you having to worry about writing it all down as I speak. I would encourage people to take an introduction course first. This may not be what you think it is. There's a writer that wrote a book, and then I pulled out one of his quotes. It said, "The difference between a sane man and an insane man is how good they are at lying." So if I would tell you that this is an easy role, I'm lying. It is difficult. Yet those who choose it find a reward both professionally and personally that is beyond comprehension. I wouldn't be doing this work for almost 30 years now if it wasn't rewarding both personally and professionally. How to be a healthcare change agent? Well, forensic nursing is going to give you that opportunity.
Great, thanks, Sheila. I think we're just approaching, or we're a bit over 2 o'clock.
Yeah.
So just one last comment from one of the participants. Just want to let the audience know that Douglas College has a forensic mental health nursing course online that nurses can take. So I would encourage everyone who is online to email Sheila if you have any questions about the presentation or forensic nursing in general. I'd like to thank you for participating in the webinar, and thank you, Sheila, for giving such a great presentation. If you want to watch this again or have any colleagues who are interested, we will archive this on our website, so please come back to www.arnbc.ca to watch the webinar again. And we will be hosting a part 2, like Sheila said, on March 15th. If you have any questions, please email us at admin@arnbc.ca, and thanks again for participating.
Thank you, everyone. And I can be reached at SGE Consulting at TELUS.net or Sheila, SHEILA _early, EARLY at BCIT.ca. And thank you for the Douglas College one. Because that's forensic mental health, I don't always include it, but I will add it to my roster too, because I don't want to certainly negate Douglas College's hard work. Thank you.
Thanks, Sheila.
Goodbye, everyone.